Here's our roadmap for today. We'll start with Hirschsprung's disease, move on to mesenteric ischemia, shift over to paralytic ileus, tackle colonic pseudo-obstruction, and then finish strong with a rapid-fire review of high-yield exam pearls.
Section 1. Hirschsprung's disease, otherwise known as congenital megacolon. Now, the absolutely crucial thing to remember with adynamic obstructions is that there's no physical roadblock in the gut. It's a functional failure. It just stops working. And Hirschsprung's, well, it's fundamentally enteropathy. We're talking about a neural crest defect that leads to a complete, literal absence of ganglion cells in both Auerbach's and Meissner's plexus across different parts of the rectum and the colon. Without these cells, proper peristalsis simply cannot happen. Clinically speaking, you really want to associate this with Down syndrome as well as MEN2A syndrome. And on a genetic level, definitely keep the GDNF gene, that's the glial cell line-derived neurotrophic factor, in mind, because it is heavily implicated here.
So how does this actually look when it walks into the clinic? Well, it kind of depends on their age. The classic acute presentation happens right away in newborns. You're going to see massive abdominal distension. And the absolute hallmark sign is their failure to pass meconium since birth. Now, here's a super highly tested clinical scenario for you. Imagine you perform a digital rectal exam on this highly distended newborn, and then immediately upon stimulation, the infant violently passes meconium. That is classic Hirschsprung's. It's like releasing a pressure valve. On the flip side, late presentations in older kids usually show up as failure to thrive or just severe chronic constipation. To actually confirm your diagnosis, you can't just guess with imaging. You absolutely need the gold standard test, which is a full-thickness rectal biopsy. When the pathologist slides that tissue sample under the microscope, they're hunting for 3 exact things. First, the total loss of ganglion cells. Second, they're looking for hypertrophied nerve trunks. And third, they want to see positive immunohistochemistry for acetylcholinesterase. If you hit all 3 of those, boom, you have your definitive diagnosis.
Section 2. Mesenteric ischemia, a vascular crisis in the bowel.
You can essentially think of this as a heart attack, but for the intestines. Let's start with non-occlusive mesenteric ischemia, or NAMI. Think of a big water pump in an apartment building during a power outage. There's absolutely no physical blockage in the building's pipes, right? But without power, that pump just can't generate enough pressure to push the water all the way up to the top floor. In NAMI, it's the exact same thing. There's no physical clot in the blood vessels. Instead, you'll see this in ICU patients with severe congestive heart failure. Their failing heart literally cannot generate enough pressure to perfuse the bowel. So your management here isn't surgery. It's giving inotropes to fix the pump itself. Now let's aggressively contrast the 2 main occlusive arterial conditions, because honestly, they present completely differently. Acute mesenteric artery embolism, or AMAE, is the most common cause overall. It's an embolism which usually gets thrown from the heart in a patient with AFib. This hits incredibly fast. We're talking a sudden, violent bowel attack with severe pain that rapidly progresses to peritonitis. On the flip side, acute mesenteric artery thrombosis, or AMT, is a chronic, slow buildup due to atherosclerosis, typically seen in the elderly. This presents more like bowel angina. When the patient eats a heavy meal, the gut demands more blood, but that thrombosed, narrow artery just can't deliver it. So about 10 to 15 minutes after eating, they get this intense postprandial pain. Over time, they actually develop a profound fear of food, which leads to massive weight loss. Focusing back on the more common embolism for a second, management is incredibly time-sensitive. Time is literally tissue here. If you catch it early, meaning under 6 to 8 hours, and there's no peritonitis, you can actually do an embolectomy using Fogarty catheters to just pull the clot right out. But if they present late and peritonitis already set in, you have no choice but to surgically resect the gangrenous bowel. And here is a massive warning for you. In elderly patients, severe peritonitis might present with a surprisingly soft abdomen because they've lost so much muscle tone. Do not let a soft abdomen fool you. Finally, remember that resecting large chunks of the small bowel carries a really high risk of the patient ending up with short bowel syndrome. Okay, so we've looked at nerve deficits and vascular crises. But what happens when the blood supply is completely fine, the nerves are anatomically perfect, but the bowel just forgets how to contract?
Section 3. Paralytic ileus, which is a failure of neuromuscular transmission.
The clinical picture here is pretty striking. You walk into the room and you have a patient with massive abdominal distension. They haven't passed any flatus, no feces, but crucially, they aren't in any pain. Now, some post-operative ileus is totally expected, but when it drags on and becomes prolonged, you have to start hunting for metabolic culprits. And here's your high-yield alert.
Hypokalemia is the single most common cause of prolonged paralytic ileus. I can't stress this enough. This trips up residents on the wards all the time. They're listening with their stethoscopes day after day, hearing absolute silence, panicking that their surgical anastomosis is failing, when in reality, the intern's lab report showing low potassium held the answer the whole time. Always, always check the electrolytes. Let's quickly walk through the exact timeline of how the bowel normally wakes up after surgery. First off, you should definitely know that the anatomical pacemaker for the entire bowel is located way up in the fundus of the stomach. But in terms of the actual recovery timeline, the small intestine, specifically the jejunum, is the very first to regain its motility. And the very last structure to wake up, that's always the colon. Definitely memorize this sequence.
Section 4. Colonic pseudo-obstruction, which you probably know better as Ogilvy syndrome. So, this is essentially a massive distension that is driven entirely by sympathetic overactivity. It's like the body's fight-or-flight response has clamped down on the gut. When you're looking at an X-ray of a patient with Ogilvy syndrome, there is exactly one number you absolutely must look for: 9 centimeters. If the diameter of that cecum crosses 9 centimeters, you are in a danger zone. The tension on the cecal wall at that size is so immense that spontaneous perforation becomes a massive, imminent risk. You have to act fast.
And how do we act fast? We use a very specific step-by-step management protocol known as the catch-pole regime. Step 1 is completely mandatory. You have to rule out a true physical dynamic obstruction first using a contrast-enhanced CT scan. Once you've proven it's purely functional, step 2 is giving IV neostigmine. This powerful drug directly counteracts that sympathetic overactivity, and honestly, it's pretty remarkable. Within minutes, the patient will violently pass stool and flatus. If that pharmacological decompression doesn't work though, step 3 is an urgent colonoscopy decompression to literally save that dilated cecum from bursting.
Section 5. High-yield exam pearls. Take a quick breath because we are entering the dense, rapid-fire phase of the review. Let's hit it. First up, visual associations. You've got to be able to instantly connect these classic X-ray signs to their definitive diagnoses. See a claw or a pincer sign? That's intussusception. The classic double bubble? Think duodenal atresia. A coffee bean sign indicates a sigmoid volvulus. An apple core deformity should instantly make you suspect left-sided colonic cancer. And please, burn this last one into your brain. The thumb printing sign means bowel ischemia. Why does it look like someone pushed their thumbs into the tissue? It's actually caused by the submucosal infiltration of air. Now, let's talk about pediatric intussusception. There are 2 highly specific, super memorable findings you need to look out for here. First is the sign of dance. When you palpate the child's abdomen, the right iliac fossa feels completely empty, but you feel this weird sausage-shaped lump way up in the right lumbar region. It's like the lump has literally danced its way upward. The second is red currant jelly stools. Parents often mistake this for normal stool, but it actually contains 0 real fecal content. It is purely blood, heavily mixed with mucus. Closing out our rapid-fire facts, let's clear up a really common misconception regarding Meckel's diverticulum. First off, keep in mind the presentation changes as we age. In kids, the most common presentation is bleeding, but in adults, it shifts and obstruction becomes the most common. Now, what's the actual mechanism of that obstruction? A lot of people just assume it's a volvulus twisting around a fibrous band. Actually, scratch that, that's false. The obstruction in Meckel's is most commonly caused by intussusception acting as a lead point. And that brings us to the end. We've covered neuropathies, vascular emergencies, dangerous electrolyte failures, and sympathetic overdrive, all of which perfectly and sometimes terrifyingly mimic a physical blockage. But remember, the absolute cornerstone of safely managing a dynamic obstruction is definitively proving there is no physical blockage first. So as you head back out to the wards, I want you to ask yourself, how are you going to utilize your imaging, like a CET scan, to confidently rule out a dynamic obstruction before you jump into medical management? Keep that question in mind, master those diagnostic skills, and I will see you in the next explainer.